I will give you a very brief introduction about our school before we start the official event. So, we are a school which is still the only one in the country for biomedical informatics programs. And we are one of the 6 schools at UTHealth Houston. And the 7th school is coming. And once it gets officially approved, we will have 7 schools at UTHealth. And we're only getting bigger and bigger. So here is a landscape about biomedical informatics across country. They are the academic forum members of AMIA, and this one is not updated. So some dots should be added, and some should be moved around for different locations. But again, it shows where the informatics activities across the country are happening. Just give you some idea about how we got here from 24 years ago. And for the pioneers of medical informatics and the people here, the honorary and other special guests, I think we started many years after the first thing was started and by the pioneers here. So as you can see, we grow quite dramatically. Student enrollment, faculty size, research expenditure, and also our endowment. And everything just grow. I have my favorite slide. I don't have it here, but it shows the correlation between Apple computer stock price and our research expenditure. The R square is 0.92. I do that every year. It's still above 0.9. So it's kind of a very good correlation. And if you are invested in our school maybe some years back, and you can all retire now. Okay, so we just some snapshot about the size of our school, and we have probably more than 800 headcounts, and many of them are not physically here. They are online students across the state and across some other states, and even in some other countries. We have about 60 some regular faculty, which means that they are paid full-time or part-time by our school. And we also have more than 60 adjunct faculty members. And in addition, we have many research staff, 140 doing research programmers, research scientists, and also admin staff. So our expenditure for the last fiscal year was about $21 million. And our budget is 34, which is still small in comparison with any clinical department. But again, we're growing, as you can see, it's a trend. So we have the full spectrum of academic programs. So we are a graduate education only, and we have 2 doctoral degrees, one traditional PhD, one applied, practice-based doctorate of health informatics. We also have 2 tracks for the master program and medical degree programs and 6 certificates. In addition, we have some 4+1 programs with some undergraduate campuses. And we have 3 academic concentrations which are perpendicular to the academic degree programs. As you can see that we have people focused on data science and AI, and clinical health informatics, and genomics, bioinformatics, system medicine, from the molecular level to imaging and integration. And so these are the concentrations for the students. But I hope soon this will become 3 academic departments. So that's what we are trying to do. Hopefully it will happen before AMIA. For our research activity, we are organized across 8 research centers plus 6 application cores. As you can see, we are across the entire biological system, from molecules, cell, and the tissue, individual population. We cover different parts of the biological system. So this is something I did actually 2 or 3 days ago. I just out of my curiosity about the contribution of our special honoree today, I searched the term HR7, LOINC, and EMR, EHR. It's not complete. I only searched this keyword, did not include many other synonyms. But again, you can see that since 1990, this is Google search pages, the number of pages that were available for a specific year. And you can see the dramatic growth over there. And so with that said, we are going to get into our formal proceedings today. And so you are going to see the honoree who have to make all of this happen. And so we're going to see that. But, okay, so the Glaser Society was created by UTHealth Houston School of Biomedical Informatics in 2015 in recognition of the expertise and leadership of John P. Glaser, PhD, who is a universally recognized thought leader in the field of health informatics. The Glaser Society was created to acknowledge innovators in the field of health informatics and provide education, collaboration, and networking opportunities for the broader community of health informatics. The first John P. Glaser Innovation Award was given in 2016 to Ivo Nelson, a notable health information technology entrepreneur. And then the year after, it was given to David Bays, professor at Harvard Medical School. And in 2018, the awardee was Steve Lieber, the former president and CEO of HIMSS, the largest health IT organization in the world. And in 2019, the awardee was Graham Grave. He's the founder of HR7 Fire, which is a new emerging standard, which is getting popular and popular every day. So, but today, we are recognizing a very special guest. And it was actually the awardee for 2020. And as you know, what happened, so due to the constraint posed by the pandemic, and it did not happen in person. So finally this year, and we are doing it here, and hopefully we can do this forever, no pandemic in the future. Okay, so now I would like to call to the stage Dr. John Glaser. Would you now do us the honor of introducing the 2022 or 2020 recipient of the John P. Glaser Health Informatics Innovator Award?
Sure, I'd be honored. So I have the honor of reading from this shortly. And you might as well get a seat because there's a long list of stuff this guy has done here. But I'm going to go through that nonetheless, and I'll honor. But before we do that, I thought I would give some personal comments in addition to that. And they go back to when I was in graduate school at the University of Minnesota, and I went to my first SCAMC conference at the time, Symposium on Computer Application Medical Care, and I attended a panel, and Clem was one of the panelists, and I don't remember the topic, and I don't remember the other panelists, but I remember Clem. And what I remember is thinking, this guy's really smart. He's also very thoughtful and very pragmatic, and he's accomplished a lot, and he's got a remarkable sense of humor. I thought, this is pretty cool. And I thought, and I could also look around the room, and it was clearly this room of 100+ people with deep respect, because they were listening intently, and to what he was saying. And I remember thinking, I want to be like him. I really do. I want to be invited on panels, and I want to, whenever I'm on there, that people will say, he's really smart, and he's really doing some interesting work, and he's got a pretty good sense of humor, and I'm going to listen intently to what he says along the way here. Now, we'll park that. We'll come back to that in a second. Now, what you're going to hear in a couple minutes is Clem describing this remarkable journey, a remarkable series of efforts that he and his colleagues have had, some of whom are in the room, to advance our understanding about how best to apply information technology to improve healthcare, but also the health of communities. And it's dealing with all the issues of the technology and what was going on at the time. And it's really quite a significant contribution. The world's a different place. It's a better place. We all are because of that work that has been done. But I also think his impact goes well beyond those efforts and the papers that happen, et cetera. It's clear to me, and I've seen this in a number of you, that over the years, dozens, hundreds, thousands of people have listened to Clem or read his papers or been his students, and they thought as I did, I want to be like him when I do that. And because of that desire, I don't doubt that the work that a number of you have done is more effective, is more innovative, and has been more impactful because of that desire. So Clem, what I think you are, above and beyond the body of work, is because of who you are. There's a force multiplier here, which is sort of rippled through thousands of people who sort of, whether they intend to or not, embody part of you and go off and do remarkable things. And I just think that's really, really cool. And they, in turn, become force multipliers themselves, across the board. So I want to thank you for inspiring me. And I want to thank, on behalf of all of us, for you inspiring all of us, because it's clear to me that healthcare and the healthcare community is better because of you are here. And if we go back to and you'll have your own list of what you want to say whenever it's that time, but I think you ought to be able to take a big smile and a deep sense of satisfaction that I left the world better than I entered it in a very big way. So thank you, sir, for that. And now for the formal part of my program here. Okay, so, no, it's great, and it's pretty cool when you get to read something that is this accomplished and this storied, et cetera. Clem McDonald has been, an innovative, hands-on, and operationally oriented contributor to the field of informatics. And in addition, he's proved himself the sort of traditional academic triple threat, an educator, a provider, and a researcher. Currently, he is the Chief Health Data Standards Officer in the Office of the Director of the National Library of Medicine. And for the previous 12 years, he served as Director of the Lister Hill National Center for Biomedical Communications and the Scientific Director of its intramural programs. His research interests focus on the electronic medical records, their use in clinical care and research, and the data standards necessary to feed EMRs and studies of their impact. Is not surprising to you. He's a member of the National Academy of Sciences, and not surprising to you, he's written extensively, over 300 publications that have garnered 18,000 citations over the years. Prior to coming to the NLM, he served as the Distinguished Professor of Medicine and Medical Informatics at Indiana University School of Medicine, and he was the director of the Reagan Street Institute for Healthcare, which is a privately endowed research institute tied to Indiana University. He developed the Reagan Street Medical Record along with a number of colleagues, which is one of the first electronic medical record systems ever introduced. And he was the first to use, or one of the first to use, the sort of study using of clinical decision support using randomized trials to see whether they really did what we thought they ought to be doing or intended to do when we do this. In addition to that, he and his colleagues developed the first U.S. Health Information Exchange that we call the granddaddy of all HIEs in many ways here, which has been the model. I remember when I was at ONC for a year, it was regarded as the model because it was successful, unlike the Santa Barbara one at the time, which was less than successful in a number of ways here, and now carries about 6 billion results across the hospitals across the state of Indiana. Now, in addition to that, you're getting tired already from all this work that he's done here. He developed the Logical Observation Identifier Names and Codes, LINC, as it's lovingly called, a database to provide universal identifiers for clinical observations, and he was one of the founders of Health Level 7, or HL7, and has been a major contributor to the Genomics Reporting chapter of the 2018 version 2 Laboratory Results Manager. And rounding the corner here, he is active in the development of FHIR, which I think you all know about. I won't go into that here, both the Genomics Reporting Center, but also the work that it's doing broadly speaking across. And that I think will have an extraordinary impact on our ability to really unleash the innovative engine that you all represent and leverage the sort of core base of EHRs that are in place. So anyway, that's it, Clem. That's enough. I mean, there's more, but that's enough. And if you want to know more, you can actually go. I think one of the neat things to look at is the Morris Collin accolades that were written by, Mark Overhage and et cetera, and others, et cetera. So with that, I think we have a special surprise for you, Dr. McDonald, if you will stay seated, and Judy will, on cue, bring it on up here. That's quite the lead-in, big guy. Anyway, it's an honor, Clem, to bestow upon you this award and all the rights and privileges that come with it. But thank you, sir. It's a great pleasure. And so now I believe the podium is yours, correct? All right, Clem, you're on.
Okay. Thank you. So John regaled us with a lot of stories about his life as a teenager or beyond, below. I mean, wild stories. I won't repeat them here. I'm going to take this thing off, though. I may need some help untangling myself from all these things around my neck. And so I want to tell you a story, some wild thing, not as wild as he was, but not bad. So when I was 6, 3 of us, one kid, the oldest was 7, the middle one was 5, and we were looking at, in Chicago, there's this, what we call the L, because elevated, but it wasn't elevated at that place, out on near Eisenhower, what's now the Eisenhower, and there was this great big bridge, and we said, we want to go down and see that, these little kids. And we pooled our money. We had maybe 40 cents, but it didn't cost much to take a subway, and said, we're going to go down and see that. And we got to it, and the oldest kid said, no, we're going to keep going. We're going to go downtown. So this is 5, 6, and 7. We're going to see my dad. Oh, okay, so we went all the way downtown, walked around on the lakefront, and then I said, well, when are we going to see your dad? I'll get in trouble if I saw my dad. So he was a little chunky, and we got back on the L, and he ate up all the remaining money with a candy bar. So we got off. It wasn't where we started. He picked the wrong line. So he made me beg. I had to go out on the street. He told me, he said, go ask for money. And, of course I did. And we got home by that formula. So, but John has better stories, but I won't take them away from you. So my story is about creating an electronic medical record and the struggles along the way. There's always struggles. People don't talk about that very often. So I was always interested in math and machines. And in 1963, I was an intern at Boston City Hospital. It was a hard-scrabble city hospital, no support of any kind, but they did have ice cream. So we were going to raid the ice cream at night, and that kind of made up a little bit for it. The interns did everything. We had to roll the patients down to radiology, all the physical, draw blood, et cetera. We were clerks and bookkeepers. Even back then, computers were doing bookkeeping for banks. So I figured, hey, maybe we could do that with computers. So then I wanted to build an electronic medical record to do the bookkeeping. So after my internship in Boston, I went to Northwestern in Chicago, which was my home, for a master's in bioengineering. Took mostly computer subjects. Then to NIH, where I managed the development of the first computerized lab system. And laboratory systems have a very similar structure to medical record systems. There are a bunch of observations stacked. Then I became an internal medicine resident at Cook County Hospital, and that was wild. We saw everything. So, so I was with the senior medical guy, and he says, here's this patient who's got a liver problem, and this green stuff is coming out. And I got the diagnosis, an amoebic abscess. So he was very nice to me thereafter. Then he got pushed out of Cook County through a political warfare, which was very, very, very ugly. And he was very loyal to Cook County. He says, oh, you stay. I said, well, are you kidding me? They drive you out. I'm not going to stay on. And then, so I fortunately, University of Wisconsin wanted me, so I went up there to finish my residency. There I met John Greist, who was a computer MD, and he told me I should go to Wishard, which is in Indianapolis, and work with Joe Mammon. So I did. It was the best advice I think I've ever gotten. Okay, I got support to build an EMR from Reagan Street. The beloved IU chair of medicine, head of the Reagan Street Institute, died suddenly. His mentor from Duke University, Eugene Stead, a most powerful medical leader, came in to take his place. He said, Clem, forget about medical records stuff. you're going to drive all around the state. You're going to set up practices, et cetera. I said, no, I came to Reagan Street to build an EMR. And a big explosion followed. You'll be a fool. You'll be a nobody, you know. And he was a pretty tough guy. But it all worked out over time, and we became friends. So that was all right. Because then we started the process of building an electronic medical record. And this was back in ancient times, from your perspective. So the technology at that time was 1972. That's what, 50 years, something like that. Large, expensive monochrome terminals, $8,000 terminals. There was an engineering grad student who decided, I can solve that. I'll make you a terminal that you can get for like $2,000 or $3,000. And he built this thing with just a whole bunch of capacitors on the table. You know, 50,000 volts here, 100,000 volts there. And he says, yeah, this will work fine up on the wards. Are you kidding? You know. Anyway, back then, computers were big and bulky, a hundredth of the size of memory than an iPhone. We had wired connections in the same building, but our computers were at Purdue, 60 miles away, and we had to only slow 60 character per second dial-in communication, and only 4 lines. So that was our beloved PDP 1145. I love the machine. It was time shared, and you must have worked with one of those. You type in the program, and the computer printed out your mistakes as you went. That was way better than the cards, because you put the stack of cards on, and of course, God forbid you drop them. You know, you're trying to figure out the order of the program statements, and then you waited, like an hour or two, and you got back errors, 2 errors, and you fix those. You put it back on, you got another set of errors. So it was really painful. Having a PDP 11 where you got the errors as you typed it in was like a godsend. So I had to work on the computers at the office because there's no internet or anything like that. And so my wife was taking care of 3 little kids at home by herself. And I'm typing on the computer in the office. I think she still remembers that. No. So we only had 4 lines. We used 2 of them for programmers, 1 for printing out, 2 of them for printing out reports. So we had to organize a medical record around paper. You know, we only had 4 lines. So what else could we do? That was our printer, and we had turnaround and counter documents. This blue, you'll see it in a minute. It was the OpScan 17. Had these little, like, window-like sashes. And if the people wrote carefully in the sash, the thing read pretty well, you know. And so that we went on, and we had, you know, we'd have to type in their drugs and a few other things. And let's see if we got another slide. And this was our initial flow sheet. So we always presented the data as a flow sheet because it seemed sensible. And then there was another report with reminders. And that was our first study, one of our first studies. Now, we'd put these things on top of the chart where physicians had to see it. And so it worked out pretty well. They'd have to lift it up and look at it. And then we believed EMRs could do good things. And we developed this thing to prove that we were right. Developing it was easy, relatively. Populating with patient data was hard, crazy hard. So we started with a defined population of 8,000 patients. And they're all from the diabetes clinic. And so we had the list of patients, and the only way we could get their data, because the clinic was much bigger than just diabetes, we put smiley faces on the address graph plates. And when they embossed them, that mark went on the slip, the 3-part slip. And we go through all the slips every night. And we write down, we type in the results. The problem was patients sometimes had new address graph plates made in the ER, and they didn't put smiley faces on them. So we lost a little bit of data. So the thing that, people didn't remember, that before you can take data out of the computer, you got to put it in. And that's the hard part of it. So these are the address graph plates with smiley faces on them. And we told the story of all that. And there were lots of breakdowns in this process, of course. If they changed the cargo plate or whatever, we wouldn't find them. And then we got a bigger computer in this time window, 1170s, PDP 1170s. Those are like manna from heaven, this big, huge machine. And it was enough to implement laboratory and pharmacy systems in a total of 20 lines. and then even bigger computers, the VAX 11, 780, and more. And this allowed online lookup of the EMR data from many sites. Now, standard messages became obvious. We needed to do something because we couldn't keep chasing down these slips and typing them in. You just had to have some systematic way. So we actually sort of stirred up HL7, started to help develop it. But as it took hold, it reduced our data entry problem, and it was more reliable as we could connect directly the output of a lab or a pharmacy right to the computer. And it enabled us to create the Indianapolis Network for Patient Healthcare. This is the Health Information Exchange. And then we still had a problem because you got this nice message in HL7, but everybody made up their own codes for the names of the observations. And so you still had a lot of work to do. So we created, well, at that time, we just would translate all the codes from the different hospitals to our standard local codes. But that stimulated us to get into the LOINC business and create standard codes so that hopefully everybody used them and they just come to us that way. And it's pretty much that way now. So in 1974 and 75, we did a couple of randomized trials. Bill Turney, who is somewhere here, where you are, yeah, published papers, and we published in the New England Journal. And it was really interesting. The editor sent me a 2-page single-space typed letter in his rejection letter for the first one, because we sent him and he rejected. And I was really proud of it, Inglefinger. And it was very encouraging, so we did it again, and the next time he accepted it. That actually made me, that everybody knew about the non-perfectibility of man, and I got invited to Harvard. I go to all these fancy places, So the results, basically we could influence providers' decisions by giving them reminders. Not perfectly, but of course the reminders weren't always right. So, everything's got errors in it. So then we added physician workstations for writing orders and at the provider's option for writing notes. And Bill Tierney was very involved in this. And the repository function, we should distinguish, when you talk about electronic medical records, we blend the repository function with the workstation function. And physicians always have loved the repository. They go to something to get all the data they couldn't get before. So we put that in first, and we got a little bit of goodwill, and we encouraged them to go to the next stage, which they did, and we were very kind to them because we worried about lots of stuff. It wasn't like administrators saying, hey, we don't let the pharmacists have to type anything in again. We let them type in free text if they couldn't get anything else in. Let the pharmacists worry about that. Now, I'm not being kind to pharmacists, but it was the only way to make it work. They could obtain almost everything. We had almost all the clinical data in this one display. And they loved the system. This is what it looked like. You're not there yet. This is what it looked like. It included problems and diagnoses and drugs and lab tests and a flow sheet. And we kind of enhanced it when we got to the web, made it prettier. And we had X-rays too, and we had an icon next to the X-rays that we tried to symbolize ribs, like a chest X-ray, but it looked like a tick, and people, so we had to take that off. They didn't like that at all. And then we got the images in there. They could actually click on it and get the images. That was fun. And there was the issue about 16-bit versus, because the images are 16 bits, and JPEG is actually 12 bits. JPEG is 8 bits. So we ended up getting the right JPEG converters and all that kind of stuff. So that was fun. And they could click on it. We got rid of the spider and made it a bone, dog bone, for the icon for the images. They click on that, and they could get to the actual chest X-rays or whatever it was they were looking at. So then we went to data orders and note capture. So we developed the first generation Reagan Street workstation for order entry. Really a dismal display, 640 by 480, monochrome. Users were not happy, and it was slow, relatively slow. But they gave us a benefit of the doubt because we've been doing this other good stuff for them for a while. Then we put PCs on the desk. still a slowish response time. And then we finally beefed it up even more, and we got it down to 1/10 of a second response time. That satisfies them. They needed 1/10 of a second, not any slower. And the advantage of having a PC and a network was there's no load on the central system, because any other thing you did, as you added more terminals, it got slower and slower and slower. This never got slower until they made us use some crazy, well, I won't go into that. So then we got color and decision support into the whole thing. And we gave them colors for every football team. And everybody could pick their own colors. Some were quite ugly, actually, but they still picked them. And then, I don't know if we have the font here, but they could pick their own fonts, too. And there's this one programmer who was the son of my boss who created what he called Clem font, which is my handwriting as a font, which is illegible, totally illegible. And some people use it. That was not a patient safety thing. But anyway, and this is, I think, the Purdue colors. So by the mid-'80s, electronic data was everywhere in U.S. hospitals. But like water everywhere in the rhyme of the ancient mariner, our AMRs could not drink it. We needed electronic data interchange standards to connect the system so the EMR could read the data. So I helped establish HL7, and I wrote the clinical chapters of orders and observation in what's now called HL7 V2. And I talked to someone from Mayo about 3 months ago. He said they're doing 4 billion, in 2 years they're doing 4 billion messages in V2 still today. And so by 1993, system vendors were using V2, and it was our salvation because we never could have kept up with the manual processes we had for the data flows. So messages needed standards for identifying tests and measures, so we invented LOINC. Bad name, probably. One of our funders said, LOINC, that rhymes with oink, it's like a pig or something like that. So it didn't do well in certain countries, actually, as a result of that. But anyway, it was there. We couldn't change it. So it's used now by all major laboratory systems, many hospital systems, and many countries, and it's been translated into 12 languages, including Chinese and Russian. The LOINC database now carries about over 100,000 items. I'm updating it. So instrument vendors and major referral labs all request new terms to add to the catalog. And messages also needed a standard for units. And Bregency provided that in UCOM. So this guy, Gunther Schadow, who is a German fellow working with me, and very compulsive, he built this elegant thing that could be computed with the UCOM strings, whatever the messages were. And it's a computable unit of measure, and it's now required by regulation in the U.S. and in many other countries. So now this is how messages looked. I don't know if anybody's ever seen a V2 message, but this is a set of blood count measures. And the green is the name of the test and the code for the test. And the purple is the value, and the red or orange is the units of measure. And I think those are all LOINC. And each row was a single observation. Okay. So physicians introduced workstations and order entry, and I think I may be duplicating this a bit. And I showed you this slide, but this is when it got pretty. You know, they had bigger computers with color monitors in the clinics, and then on the wards, they had these slick LED monitors, and that's what they did in Brown's time. Everybody was on the machine. And they actually, we couldn't prove this because we didn't do any surveys around this time, but they actually liked it. Or they didn't hate it, let me say that. Now, I mean, compared to what they do with it. But we were very sensitive to their needs. So my brother, who's an ear, nose, and throat specialist, he hated the system in Madison, Wisconsin. You can just guess what system that was. And he said he would, though, I can't put in I want this special thing for the neck or throat. And he'd go around the corner and call the nurse and write a verbal order to the nurse over the phone. So one of the real problems was that you had to pick something from a menu. So what we did, they could always type in free text as an option. And let the pharmacy worry about translating it into a code rather than them having to worry about it. Now, these were high resolution now. We used DOS rather than Windows as our operating system, and we wrote in assembly language, and it was fast. Man, it was really fast. I mean, I think we were below 5 milliseconds per response time. And then we let the users make their own color patterns and their own fonts, and that was a little dangerous when they had Clem font that no one could read. Let's see. And then they liked them because they were fast, and we had rich synonymy. I've said some of this already. We allowed them to enter visit notes, and maybe half of them did. There was one guy that could type 120 words a minute, but half of them didn't either, and they stayed happy. And so Bill and I, Tierney, who's up there still, published a JAMA paper that showed that this system, this order entry system, shortened length of stay. And our primary mechanism of data presentation was always a flow sheet. By 1979, we offered flow sheets online. Then we connected all the hospitals in the city into one system to unify the medical record fragments scattered around the hospitals. So electronic health information exchanges, HIEs, Reagan Street introduced the first one. We called it the Indiana Network for Patient Care, and it evolved into IHIE, which is Indiana, all of Indiana, which continues to operate. We could not have done this without the standards that were percolating up into the system. So anyway, now the data included, we had everything from, there's 6 or 7 hospitals. We had everything, well, I don't have to read it, it's not that interesting. In 2006, when I was leaving, it had 815 million records, more than 1,500 message streams from about 100 systems, and report delivery push with docs for docs to more than 90% of the physicians in the city and in the state. Today, as the Indiana Health Information Exchange, it includes 17,000 practices, 15 million patients, 12 billion items of patient data. So it's big. In 2020, there were probably 100 IHIEs operating in the U.S., I think. Research and discovery. Now, so back in the thoughts, computers should do 3 things. They should provide logistic solutions to physicians getting at their data. They could provide decision support. We didn't call it that back then. And they could provide new understanding by looking at all the data collectively, we thought. So we used it for research. And for the Dean of Research, it was used in 80%, and Bill can either deny this or correct it, 80% of the IU studies to find cases that they would use in their randomized trials. It also reminded physicians of the ongoing studies that could benefit their patients. It was the source of data for the one famous IU study that discovered that erythromycin was the cause of pyloric stenosis, at least statistically, 20-fold odds ratio on it. And there was a lot more to say about Reagan Street Medical Record and Research. It was basis of facility. There's hundreds of papers and tens of thousands of citations. Bill Tierney invented, he's up there, invented machinery for inviting patients into studies based on that system. It was the publication engine for Reagan Street, and proved much of what we believed about EMRs. He and his team cumulative total of 54,000 potentially eligible patients, of whom 42,000 were eligible, and 25,000 were enrolled into 90 different studies. It was really a great system. Now, this is where I am in 2006, NLM. That's the building 38A. I'm still there. I'm still working with clinical standards and medical records at NLM. Continue involvement at LOINC, working in terms for genetics and newborn screening and many kinds of survey instruments. Overseeing and encouraging deep learning on images and text narrative. Big involvement with HL7's newest standard, FHIR. Developed FHIR EMR software tools for use in EMRs, flow sheets, and forms. And working on the research payoff of large medical data larders. So we were working on Medicare data for a number of things. and we showed a number of things, including that PPIs are not dangerous. It's actually the phenomenon seen that's like omeprazole for acid stomach. The phenomenon seen is really a flaw of it's a particular type of bias, and I'm going blank on it. Maybe it'll come back. But anyway, you can prove it if you shift the data time frame ahead, and it goes away. And it did go away. Carl Sagan used to talk about billions and billions of stars. We can now talk about billions and billions of data elements in many, many different systems now. HL7, I'm going to talk about FIRE. It's pronounced FIRE. I imagine you all have heard of it by now. And there's a guy who won this award a couple years ago, introduced it, and he's really quite amazing, because he just focuses on this thing and keeps controlling it. So it's a little bit, Linux is this open source thing that everybody can do whatever they want with it, but it's controlled by an iron fist with Tavoris, the guy that founded it. And I think that the same thing is true of FIRE. He actually has a very strong hold on it, although it's open and you can do whatever you want. And that's why it's worked, I think, because of that. So FIRE is, I guess I'm probably talking to the choir on this one. FIRE? Yeah, well, I'll do it anyway. It's an elegant, flexible, easy, and free HL standard with a familial resemblance to V2, which is good because people understood that and they could kind of march up. The documentation is free and available on the web. It's agnostic to underlying technology. It can be expressed in XML or JSON or Turtle, if you want to do that. The most popular open source FIRE server is Happy from Smile. I have two different words. That's a company. You can just download it for free. I fell in love with FIRE when I was reviewing data standards. So CDA, which you guys probably know something about, is this kind of obese, overstated. Sorry, John, I don't know if you're a fan, but you got to read a lot of pages to get to 1,000 pages to see the thing, and they could have made the font smaller probably, but so I spent probably half a day trying to review the first second standard of that type, and then the next hour I got a hold of the FIRE standard, 88 pages. I reviewed it in an hour. I said, this is good. So I've been a fan of FIRE ever since. So everything is based on resources. Think of these as just sophisticated tables where you can put in multiple values and things. There's one for patient registration, one for any kind of observation, and there's lots of others. Even its internal definitions about how it works and everything are defined as resources. So it's sort of a bootstrap system that pulls itself by its own bootstrap. The ONC federal final rule, actually this is old hat, you got to use FIRE. It's embedded in regulation now, and there's lots and lots of tools for FIRE in GitHub. Its tension has this. It has spread like wildfire. Lots of ways you can use that word FIRE, and meaningful use, which came out with that word, got translated into you had to use FIRE. So it's a regulatory interest, and all the big IT vendors are doing something with it. So at the Lister Hill Center, we built a number of tools for FIRE medical records. We built tables for commonly used tables in EMRs, including things like CPT and NPI and things like that. UCOM units, a measure validator. So this UCOM is a syntax. It's not an enumerated set of codes. So it really needs a validator, and we built one. And then there's some other forms like LHC FIRE Forms, which implements FIRE's questionnaire. And it actually is a live form. You build this thing in JSON, and it pops up on the screen, and it has all the kind of things you'd want in any kind of input form, and a flow sheet too. And if you ever want to get them, they're here. I'm not going to go into this too much. So the FIRE Forms is really very sophisticated. you can make it shrink or grow. You can make it. It can have nested variables. It has answer lists. It has all the stuff you'd want in a form. Skip logic, all that kind of stuff. And then the last thing we worked on is Medicare VRDC. VRDC is Medicare's big database, which is cleansed. It's de-identified. It carries almost all medications, all encounters and diagnoses, and all procedures. And also vital status for up to 11 years. So what it's got is all the inputs to healthcare and the outputs, more or less. They live or die. Did they get a disease of any kind? Did they have to have surgery? So we've done a number of studies. Does anti-testosterone treatment for prostate cancer cause dementia? And our answer is no. Is metformin a fountain of youth? Because people were talking about that at one time. And our answer is no, but I think statins are, when we look at these long Cox regression analyses. Is estrogen bad for older women? There are 10 million women on estrogens in Medicare's database. They're menopausal. And our Cox regression analyses suggest it ain't bad. It actually, there's a 20% reduction in the hazard ratio of mortality. There's a 20% reduction in breast cancer mortality. And actually the randomized trials, Women's Health Initiative, shows the same thing, but it's been ignored. There's a reduction use of estrogen. The confusion is estrogen and progesterone is a different thing. So, and then there's another complication there, is you can't use just estrogen alone if you still have your uterus. But anyway, so, and then another study is, do fluoroquinolones cause tendon rupture? We think not. And do PPIs cause deaths? And we know not, actually. Now, observations, these are all observational studies, and they're tough. But they offer tantalizing possibilities, especially with mega databases with lots of statistical power. We've now started mixing Cox regression with deep learning just to be sexy, I think, mostly. It doesn't really do much more than the plain old Cox regression. But it's been fun figuring out how to make them work together. Now, it took a village. Barbara McDonald, my wife, she put up with me for decades. I mean, from actually a whole marriage life, because I was working on the computer way too much, way too much. And then these other people, Joe Mamlin, I won't. You don't know these people, but there's a lot of people who were behind me in helping me do the things I talked about. So that's all I got. So thank you.
Okay, thank you again, Clem. This actually marks another red letter day for our school. Absolutely. And at this time, I want to take the opportunity to introduce another special guest sitting right over there, Bill Tierney. And Bill is a dear friend and colleague of Clem for 40-some years. And together built a lot of things in Indiana. And so Bill is currently a professor at Biomedical School and also the Associate Dean for Population Health at the School of Public Health at Indiana University. So both Bill and Clem are elected members of the National Academy of Medicine. And thank you for coming, Bill. We are indeed privileged to be here with all of you, as well as the thought leaders. All of you every single day trying to solve the hard problems. And even everything was started 40-some years ago, and we still have more problems and to be solved, as Clem mentioned that hopefully someday AI can help a little bit for the EHR systems. So at this time, I would like to invite all of you for a reception, which is right across the concourse on the other side of the building. So again, thank you so much for your attendance here, and thank you. Enjoy your reception. We do have something which is not pizza. Hopefully that will help. Okay, thank you again.